So let's make a start, shall we? So welcome to the webinar on improving how physical activity is assessed in primary care. This is part of the series of webinars hosted by the NIHR Policy Research Unit, Healthy Aging. And this particular webinar is in collaboration with the Policy Research Unit in Healthy Weight. We're going to be discussing our joint research projects, which examined how the General Practice Physical Activity Questionnaire, known as GPPAQ, is used in primary care and community settings. Now, for information, this webinar is going to be recorded, and the video will be posted on the YouTube channel, and a link will be sent to everyone who registered to attend. Throughout the webinar, we will be posting links to related research in the chat as we progress. At the end of the presentations, we're going to pause and provide an opportunity for questions. So please look to the top of your screen or wherever it is on your screen, because some operating systems differ. So if you would just have a look at the chat and look for the Q&A function. If you press the Q&A option, you'll be able to post questions as well as give thumbs up, etc. to questions posted. We know from experience that the question and answer function doesn't always work depending upon settings from your host institutions. If you're not able to post into question and answers, just use the chat in the normal way, and we'll do our best to keep an eye on that and put that into those questions that appear in the chat into the Q&A. Right, so to move on, we've got 3 talks today, and basically we undertook a rapid review of international research to see how well the GPPAQ compares with other tools. We then used primary care records, routine data from Clinical Practice Research Data Link to see how GPPAQ is used in everyday practice. And then we held a workshop with health and physical activity experts to talk about what we'd learned and decide how to proceed from there. On the basis of this, we're hoping that this will help us understand whether GPPAQ is the best tool, how it's used to assess physical activity, and to consider what other tools and options might be open for the future. So if we just, as I said, this research is funded by the NIHR, so if we could have the funding statement up so that it's quite clear what we've done and who's funded this. And I'll turn to the first of our 3 speakers, who's going to be David Sinclair, who's going to be talking about characterising the use of General Practice Physical Activity Questionnaire in primary care using the Clinical Practice Research Data Link. The second speaker is Disha Dar, and she'll be telling us about brief tools for the assessment of physical activity in primary care settings and expert-informed narrative review. And the third of the 3 speakers is Kimberly Lazio-Green, who's going to tell us about the results of the roundtable on tools to support measures of physical activity in primary care settings. So, without further ado, we'll turn to David. Thank you.
Okay. Hello, everyone. So I'm David Sinclair. I'm a lecturer at Newcastle University, and I'm going to be talking a little bit about some research we did looking into characterising the use of the General Practice Physical Activity Questionnaire in English primary care. And this is work that is led by Laurie Davis and some of our other collaborators as part of the Policy Research Unit. But Laurie is on annual leave this week, so I'm stepping in. So the General Practice Physical Activity Questionnaire, it's been around for about 20 years now in primary care, introduced in 2006. It was briefly in the Qualities and Outcomes framework. There's been financial incentives for GPs to use this in the past. And the idea is for it to be a quick to administer tool to kind of characterize how much physical activity a patient is doing, and whether perhaps the GP should suggest some sort of intervention to kind of increase the level of physical activity a patient is doing. And we know that as part of the NHS's the 10-year health plan from the government, that one of the things that's going to have to kind of improve there, we've got the prevention shift, and more physical activity, improving the amount of exercise people are doing is going to be really important as part of that in general, as part of healthy aging. So we wanted to understand, this tool has been around for 20 years. It should be relatively well established here, but how much is it actually being used, and how is it being used in general practice? And there wasn't a lot of data out there about it. So we set about trying to have a look. So we wanted to look and see, how it is used in routine general practice. When is it used? Which members of staff are completing the GPAC with patients? Which kinds of patients seem to be having a GPAC versus which ones maybe aren't? And whether there seems to be like some level of advice or interventions that at least are coded in the records afterwards once the GP has conducted a GPAC. And to use it to kind of investigate this, we use data from the Clinical Practice Research Data Link, which is also called CPRD. And this is a wonderful resource. It gets electronic health records from about a quarter of GP practices in England. It's updated every 3 months or so. And so it's a really rich treasure trove of kind of anonymized electronic health records that we could use to go and see, okay, is the GPAC being used, or at least is it being coded in people's records once it's being used? And so we set about getting some data sets from CPRD, and we looked at 2 related data sets. One was to say, let's just randomly select 1 million patients from the electronic health records, and just to see how many of them have ever had a GPAC, in their records. And then we also spent a bit more time looking more closely at the 1.8 million patients who had a GPAC recorded in their records over a 5-year period from 2019 to 2024. So to start off with, we had this 1 million randomly selected patients. So these are all adults, but other than that, just complete random selection. And 9% of them had a GPAC recorded, at least one at some point in their electronic health records. Mean age was about 55, 52% were female, so fairly even gender kind of distribution there. And in terms of the patients who were most likely to have a GPAC, we saw that there's an association with certain kinds of diagnoses of conditions, and in particular things like patients diagnosed with pre-diabetes or who are kind of observed as being overweight, or a much higher probability or a greater proportion of them had a GPAC included. So not that many people in the grand scheme of things were recorded with pre-diabetes, but of those that were, half of them had a GPAC. And again, of everyone who had the observation of being overweight, more than a third of them had a GPAC in their records. And this is a list of conditions that are all kind of broadly associated with things that would generally benefit from increased physical activity. And yet there seems to be, an association in that when they're getting observed to have these conditions, quite a lot of them having a GPAC, or at least higher than the baseline level of 9%. When we looked at the 1.8 million patients who had a GPAC recorded over a 5-year period, so this is from 2019 to 2024, if we looked at the age distribution, so that's this plot on the left, nearly every patient was between the ages of 18 and 74, with only a small proportion of 75 plus, which is quite nice because the target age group for the GPAC is 18 to 74. So it's it seems to be being used for the patients it was designed for. It's being used across all age brackets, although less in younger stage groups. More commonly seems to be being used in kind of middle age and early older age. And in terms of how many GPAC recordings patients have, so about half of patients only had one recorded, so that's this red band, but quite a lot had multiple instances of GPAC being recorded in their records over this 5-year period. So it seems that in lots of cases it's being done multiple times, I guess, to see if levels of physical activity are being changed and to kind of keep an ongoing record. So that's quite nice to see. And amongst those patients who had a GPAC done, Nearly half of them had the GPAQ done on the same day as a cardiovascular health check, and nearly 20% had it done in the same day as an NHS health check. So it seems to be being used with other health check tools to kind of get an understanding of patients' overall health. And it's perhaps interestingly, rarely was it being used on the same date as a new patient appointment, tending to be happening, when other health checks are happening instead. And amongst the patients who had a GPAQ recording, a lot of them, as with our random sample of 1 million, of all the ones who had a GPAQ recording, a lot of them had conditions like diabetes, lower back pain, hypertension, things that will benefit from perhaps increased level of physical activity. Lots of them also observed with cancer, which is interesting. But yeah, generally, it seems to be being used kind of appropriately in situations where physical activity would, perhaps be beneficial for patients. Amongst the staff who are recording it, so one of the things we get from these electronic health records is we get data on who's entering that record. So, and if we use that, if we assume the person who's entering it is the person who's conducted the test, which isn't always going to be the case, but as an approximation, we see that it's really actually the GPs themselves who are conducting the GPAQ. It tends to be more healthcare assistants and nurses who are conducting it predominantly. And in terms of after a GPAQ has been recorded, in about 60% of the time, there's some intervention happening either the same day or at a following point in time, which is nice. These tend to be interventions like advice to, for exercise-related activities, advice for weight loss, advice for diet or nutrition. Sometimes it's also followed by another GPAQ, and maybe in about 43% of the time, there's not another recording indicating a follow-up intervention. Now, that doesn't mean it hasn't happened, it just means it's not recorded. It might also be the case that if the GPAQ is being used and the patient is found to be having, a healthy level of physical activity, then maybe you wouldn't have an intervention afterwards. So these numbers seem, pretty promising in terms of advice being given after the GPAQ is being done. So to summarize, what we know, it seems to be being used to target high-risk individuals, and rather than a complete population approach. And this is in line with guidance. So it's monitoring consultations. It's used in monitoring consultations for long-term conditions. It's often followed by relevant interventions, and it tends to be administered by healthcare assistants and nurses. Things we weren't able to kind of figure out from this data set were, is it associated with short or long-term changes in activity or health status? Does the impact on inactivity and health differ when used opportunistically rather than in long-term condition appointments? And what are the costs of GPAQ recording activity, and are they justified based on the health benefits? So these are all questions that we might be able to look into in the future, but for now, we've just kind of done a relatively quick kind of understanding of how is the data being used, which patients the GPAQ is being used for. But yeah, thanks a lot for listening.
Thank you very much, David. Well, we'll be then moving on to our next speaker, who's Disha Dar from the Healthy Weight Policy Research Unit. So Disha, if you take control and
perfect.
Move on.
Thank you so much, Chris.
Questions, and we'll do all the questions at the end.
Yeah. So thank you everyone for joining today. I will be presenting the next part of this project, which includes findings from an expert-informed narrative review, looking at brief assessment tools used to assess physical activity in a primary care setting. So let me start us off by just outlining the objective of this work. We aim to conduct an expert-guided rapid review to evaluate the strengths and weaknesses of the GPAQ and other alternative tools as well. We specifically aim to identify appropriate physical activity assessment tools and evaluate what they mean to measure. We also assess their feasibility, so things like how long they take to carry out, how many questions they include. We also wanted to evaluate the reliability, accuracy, and validity, and importantly, also look at if they're acceptable in primary care healthcare settings, as well as inclusivity across different population groups. We also wanted to go beyond the tools themselves, considering what additional information might be needed to inform physical activity interventions, as well as highlighting key gaps in the evidence through this work. In terms of our methods, we first consulted with academic experts as well as GPs to shape the scope of our review and the focus of our review. We then carried out a review of reviews, identifying 10 relevant reviews, and this was followed by a rapid non-systematic review of primary studies, from which we were able to identify 24 studies. We then brought all of this together through thematic integration, allowing us to compare the tools and identify consistent patterns or gaps within the evidence. This ultimately informed a narrative review and a cross-tool comparison. So what do we focus on? We focus specifically on tools for primary care. And so our inclusion criteria, when we were looking for our studies and looking for reviews, we wanted the tools to be designed primarily for primary care and also for them to be brief. So typically can be completed within 2 to 4 minutes. So the first four tools you see highlighted are the ones we've included in our narrative synthesis, and this includes the GPPAQ, the exercise vital sign, physical activity vital sign, and the International Physical Activity Questionnaire short form. There were a few additional brief tools that you can see on the slide, but our narrative synthesis focused on the first four, as this was the most frequently cited or referenced by the experts, as well as these four tools had the most strongest and consistent evidence. So to compare these tools, we used several key criteria, as I mentioned earlier, and our criteria was developed using an already established measurement framework known as the Cosmin taxonomy. However, the evidence base did not provide sufficient detail for each of these properties, so we used a shortened list to assess the performance of the different tools. Quickly to go over the criteria, we looked at validity, which means are the tools measuring what they intended to measure. Accuracy, which is looking at how well are the tools identifying those who are truly active and those who are truly inactive. Reliability, which is looking at how consistently are the tools producing the results. Feasibility, it's about how practical it is. Acceptability, whether patients and clinicians are comfortable using this tool. And lastly, inclusivity, which is looking at how well the tools work across a diverse population. So what did we find? First of all the tools were broadly feasible as well as acceptable for use in primary care. However, there were important differences. In terms of validity, most tools demonstrated poor to moderate performance, with PAVAS being showing the strongest validity amongst the other tools. GPPAQ, EVS, and PAVAS were reasonably good at identifying inactive individuals, but were less strong at identifying those that were truly active. And inclusivity was also a concern for all four of the briefing tools, but particularly for GPPAQ, which performed very poorly in this area, and I will go further into it as we move on. And for some tools, such as IPAQ short form, there was very limited evidence in certain domains, and this identified, evidence gaps and what we can do with this research further. So now to summarize these findings, the four tools were all feasible, acceptable, and generally reliable. They were also all reasonably effective at identifying inactive individuals, which is very important for primary care and for what these tools, how these tools can be used in primary care. This identifying inactive individuals, this GPPAQ works pretty well. However, these tools do lack depth and they do not capture the full intensity of the exercise being carried out, the frequencies of the exercises being carried out, or the context behind these activities. They also showed low validity compared to objective measures such as a pedometer, and they tend to focus mainly on aerobic activity, missing strength and balance-based activities. So while these tools can be very useful for primary care settings, they are often very limited in how much they capture and what overall they tell us about physical activity. And then coming back to GPAQ, and as I had mentioned earlier, it did lack, or it performed quite poorly when it came to, measuring different populations across a diverse group. And as GPAQ is currently one of the tools being used in the UK primary setting, we also explored how it could be improved. One key area was better capturing activity patterns in older individuals. For example, GPAQ Walk, which included modifications to the questionnaire, improved its sensitivity, and further adaptations also increased this even more in older populations. So there's potential to also include muscle strengthening, balance activities, which align with the updated Chief Medical Officer guidelines about physical activities. And also further improvements can be made about how the GPAQ is scored. Instead of giving us broad categories, it could be more granular, point-based approaches. And these changes could improve accuracy as well as usefulness in primary care settings. So considering our limitations, it is important to acknowledge them. In our approach, this was a very rapid piece of work, so we only used a single database and we may have missed some studies. Secondly, the focus of our review was also we wanted to look at tools that could be used in the UK setting. So this is the research is biased towards UK tools, and we did not conduct a formal risk of bias assessment. Limitations of the evidence itself, we noted that there was a lack of high quality evaluation studies looking at these tools in primary care setting. There was also considerable variation observed across the studies in terms of the methods they used, the criteria they used, and how they reported their findings, which made comparison a bit more difficult. Lastly, again, because there is a lack of a standardized criteria used to assess these tools, it further adds to it making it more difficult to compare tools head on. And this leads me on to the gaps in our evidence that we also noted, and there were several, and the three that I would like to discuss today would be that we found no studies that had any head-on-head comparison of these tools, very limited research on additional information that may be needed to guide interventions and help people that are physically inactive, and a lack of studies reporting on inclusivity across the population was another gap in the evidence that we noted. So this leads me to our key research priorities. I think developing a standardized criteria for evaluating these tools could better inform and could give us a better understanding of how well these tools are performing, and also conducting more research on inclusivity and the real world use of these tools would be something that we could hope for with future research. And in terms of finally thinking about how all of this work leads into policy and practice, the key message here is that tools do matter and they're important, that we have tools that we can be using, but it is also important how we use these tools, and and that is just as important. So we need to consider how physical activity assessment can be integrated into clinical workflows, and what is happening after the assessment as well, such as referrals, social prescribing, and how these tools can also support holistic approach of physical activity. This includes considering patients' capabilities, their opportunity and motivation to carry out physical activity, not just measuring the level of activity they might be doing. And that's everything from me. Thank you so much. And I would love to take questions at the end.
Thank you very much, Disha. And as Disha said, we'll take the questions at the end. I haven't seen many questions in the question and answers yet or in the chat, so please do use those facilities. Okay, so let's move on to Kimberly. That's so Green, who's going to be telling us about the results of the roundtable. Over to you, Kimberly.
Thank you, Chris. So good afternoon, everyone. My name is Kimberly Lauser-Green from the University of Manchester, and I will be presenting today on the findings of our roundtable on tools to support measurement of physical activity in primary care settings. So from the previous presentations, we have talked about how GPPAQ is being used in general practice through the secondary data analysis of the Clinical Practice Research Data Link. Then we looked at the evidence on a range of brief assessment tools currently used in primary care through an expert-informed review. To bring all the findings together, the Healthy Aging and Healthy Weight Policy Research Units have organized an expert roundtable, and the objectives are to review the findings from the 2 previous studies, to facilitate an open discussion, and to gain insights, feedback, and consensus that will inform recommendations for policy. To ensure that we get a broad range of experts in our roundtable, we sought representation from 5 key groups, and these are the academics, primary care and neighborhood health, alternative tools, system-level NGOs and charities, and system-wide representation. We had a total of 7 experts who joined our roundtable, and the session was chaired by Jamie Blackshaw, who is the Physical Activity Policy Lead from the Department of Health and Social Care. The expert roundtable highlighted a range of perspectives on the use of physical activity assessment in primary care. The first key discussion point is on alternative tools. Some of our experts have preference on the exercise vital sign and physical activity vital sign, primarily because these alternative tools are shorter, can be more sensitive, and are more aligned with the government guidelines on physical activity. Moving medicine, for instance, use EVS because it is easily integrated into many hospital electronic patient record systems. The second discussion point was on inclusivity. The experts have raised concerns on the ability of some of the tools to capture different types of activity across varying functional abilities and occupational roles. It was highlighted that there were some instances where GPPAQ may not accurately capture occupational activity, so this means that those in manual or trade occupations may be classified as inactive despite achieving the recommended activity levels through their work. Another discussion point was on the purpose of assessment. The experts agreed on the importance to identify those who may benefit from support and intervention. They reflected on the impact of interventions following GPPAQ, highlighting the absence of a standardized pathway that links assessment to next steps. And this could be things like a brief advice, referral, or social prescribing. This raises the question on whether assessment leads to meaningful behavior change, recognizing that follow-up should also consider the individual's capability, opportunity, and motivation to increase their physical activity. So, for example, older adults and less active individuals are less likely to report having conversations about physical activity, and those who are already more active appear more likely to engage in such discussions. So where conversations do take place, they often lead to attempts to increase the activity. There were also huge talks about the increasing role of digital health, which includes the NHS app and other device-based measurements of physical activity, such as smartphone step counters, wearables, and body-worn sensors. The advantages of this are that it has greater objectivity compared with self-reported measures. They have alignment with the broader digital transformation across the NHS, and they are useful conversation starters in consultations. But the experts have cautioned on the risk of digital exclusion that may increase widening health inequalities. And this particularly pertains to smartphone ownership in older and socioeconomically disadvantaged groups, which may limit the reliability and equity of digital approaches. The experts have also emphasized that tools should be a prompt for discussion, and this means that it should be quick and efficient to use during short consultation times. This would enable the assessment tool to be a prompt for a more meaningful and personalized conversations. The experts have also stressed that what follows the assessment is most important because categorization on being active or inactive alone is unlikely to drive behavior change. Lastly, practice variation was highlighted. GPPAQ is most commonly used where it is embedded in structured pathways such as NHS health checks and cardiovascular reviews, but a lot of practitioners either find it unhelpful or do not routinely use it in practice, and incentives are often required to support widespread adoption of tools. So if we integrate these tools into processes like new patient registration and health checks, then more people are likely to be assessed, although this does not guarantee that a meaningful engagement will happen. And so what does this mean in terms of policy? So the expert group agreed that the policy focus should not be asking which single tool should we use, but rather what set of tools is needed to assess physical activity effectively and inclusively. The experts are advocating for a menu of options that can be adapted to different populations and clinical contexts rather than relying on a single standardized tool. Second, the experts have noted that patients often find the use of objective measures from smartphones and wearables more engaging and accurate than self-reported questionnaires. And so policymakers should consider how physical activity assessment should be flexible, inclusive, and better integrated with digital health. Lastly, our experts have highlighted the importance of separating population-level surveillance and individual clinical assessment as two distinct policy objectives. And what we mean by this is that capturing physical level data at a population level for public health and research purposes should be a separate issue from physical activity assessment for clinical purposes in primary care. And so to summarize the findings of our roundtable, the key takeaways are that first, the central issue identified is not on selecting a single best tool, but on providing primary care professionals with a range of options depending on individual and contextual factors, as no single tool is able to meet the needs of diverse population groups. This approach gives the opportunity to improve inclusivity, engagement, and relevance for both patients and clinicians. Second, the growing role of digital health infrastructure to support physical activity assessment is acknowledged. Incorporating the use of wearable devices into health checks may present an opportunity to develop their use in routine practice, but we must be cautious on the reliability of the data. The final point is on the need to clarify the purpose of physical activity assessment in primary care. Primary care has a broad remit, but resources are primarily directed at individual patient care. And so assessment should focus on identifying inactive people and not measuring physical activity levels in people who are already active. This means that primary care data will be of limited use for surveillance of physical activity in the whole population. Assessment is also about engaging people and part of a conversation to promote physical activity. And while measurements are important, impact depends on how assessments are used, particularly on the quality of subsequent conversations and interventions. Thank you.
Thank you very much, Kimberly. So that's at the end of our presentations, which I hope you all agree were excellent. Good piece of work, doing a great overview of how GPPAQ is currently being used and what the options for the future might look like. We haven't got an awful lot of questions in the Q&A. I don't know if there's more in the chat, but so I'll start with the first one that I can see, which is to Disha. Thank you for your presentation. Do you think you could give us a few more details about the inclusivity aspect of the tools? And maybe if we stop sharing the presentations, we'll be able to see the speakers' faces as they answer the questions. So,
Yeah.
Sadisha, could you address that question, please?
Yeah, I mean, when we chose inclusivity as one of the criteria for assessing these tools, we were looking at how well they would perform on a diverse population. And in terms of when we're looking at physical activity assessment tools, the main inclusivity factor was around how these tools perform with older individuals, as you know, the exercises that they're performing or the amount of activity that they're doing might be sufficient for their age groups. And so in terms of inclusivity for these tools, we specifically focused on how these tools worked for older individuals, and obviously they weren't capturing the activity that was being done very well. And so by adding modifications to the GPPAQ, for example, counting, how much the individuals are walking, or, doing different activities like climbing stairs, or just, leisure exercises as well. It improved the physical activity that was being assessed, and it showed that older individuals were doing the activity that was required of them. And in the evidence, there wasn't a lot of discussion or any results reporting on how these tools worked on different groups or different populations. I think that is definitely something that we would require further research on and can be looked more into. But yeah, that was one of the evidence gaps that we also did identify, that there wasn't much information about how these tools may differ across diverse populations. I hope that answers your question.
So, well, yes, but actually there's a couple more questions to you, which really carry on with this theme. So another question was whether you found anything on GPPAQ and how it impacts individuals who've got lower limb, or it doesn't say lower limb loss, or who live with mobility difficulties. So did you identify anything specific for those sorts of groups?
Sorry, I'm just looking at the question again. No, we did not find anything on that, no. But there's very limited evidence at the moment. Look, assessing these tools in general, but those were definitely things we carried on in our report and said what we would like to do further is looking at, the inclusivity factors of all these tools.
Another comment which comes from a GP practice in central Manchester, in a deprived area of the city, saying it's not so much a question, saying that they're now using the HAPRU tool, building an approach to integrating physical assessment, refer and follow up within their consultations by all their clinical team. That's very good to hear across their teams. But they also found that GPPAQ is not wildly helpful with their patients. I think that's something that seems to be coming out overall from our research, that GPPAQ may not be. Now then, there's another question here. Let me see. From Public Health in Manchester, been meeting recently on the suitability of the questions for older people, and they're wondering about the next steps in this piece of work, as to how different tools can potentially exclude people who do not exercise, and it's not being picked up by the questionnaire. Older people who maybe do lots of working but doesn't get out of breath is being commented on. So I don't know, that's probably for both Disha and Kimberly to comment on from the roundtable as well as the review. But if you kick off, Disha, then Kimberly maybe.
Yeah, yeah, again, this was something that we spoke about on the roundtable as well, how these tools can exclude, have the potential to exclude people who don't exercise, as well as I saw one of the other comments in terms of it being in English as well. That's another way of how it can exclude individuals. Kimberly, did you want to add anything on about the next steps for this piece?
There are translations, aren't there, Disha, of
GPPAQ
to other languages.
But I think it was also about the language used in these questionnaires, and how well the patient is understanding them is something that we also did discuss, that, you know, just asking how many how much exercise did you do in one day, that's quite difficult for someone to understand, because there's different ways of doing exercise. People are doing different types of exercise. I think that's another limitation we noted of the questionnaire in general, that could potentially exclude people from using the tool properly, was just that it is very top level, very high level. It doesn't go into a lot of detail, so it's difficult to pick out those details about what physical activity is actually being done.
Yeah, and I think just to add on what Disha has already said, you know, the roundtable has picked up on why it's important for us to, you know, develop or find a set of tools that would be inclusive and effectively assess physical activity at the same time, because it has been shown that GPPAQ is not picking up all these different factors that are from the patients, basically from physical activity levels.
There's a further comment about HAPRU being slightly easier language-wise for patients whose first language isn't English. And then there's a comment about whether GPPAQ was actually designed to be used for repeated measurement to look for changes in activity levels. And that is possibly the case. Maybe Disha would like to comment on that. But I'll have to say, as a researcher, when I'm looking for changes in activity, my go-to questionnaire would not be GPPAQ. But that's, as a researcher, maybe wanting to look at population changes in activity levels. So would you like to comment on its sensitivity to change?
Sorry, I'm just looking at where this question is, but yeah, I mean, you can. Yeah. Have I got it right? Is it? Yeah, no, but with the GPPAQ, again, it should be used in standardized routine health checkups. So it does have that aspect of, routine checks. And we did find it was reliable, but it also doesn't perform the best at it's not the most reliable tool either. So I think, yeah, I think the use of the tool is still something that, we have been discussing as a team, and going back to DHS as well, that where do we want to fit this tool and how we want to use it was something that we talked a lot about in our discussions in the stakeholder meeting. And I think that is for more further work that needs to be done to understand, is it meant to be just a check for, surveillance about physical activity levels in the population, or is it something that we can use consistently and use it as a measure to look at, how physical activity levels are changing at an individual level. But I don't think I have a concrete answer for that. I think it's something that will need more work looking into and seeing how this tool will fit and where it will fit best. Yeah. Anyone else, if they wanted to add something to that question, maybe?
David looks like he's wanted to say something. Or
no, I agree with what Disha's saying. I think, yeah, the GPPAQ, it's a very, again, it's a quick tool to categorize people into very broad categories of physical activity. You can, if you have multiple measurements, you can use that to track some sort of change, but it's certainly not the best tool. But if it's being used for enough people in these routinely collected data sets, then it's still something we can use to look at longitudinal change, even if it's not ideal.
One final question I'm going to take from the chat here, which is pointing out that if the tools are seen as being limited, they can do, as you say now, not picking up on the specific details, is going into more detail, asking these questions, using these tools in contradiction or in opposition to the recommendation that the tool should be quick and short and used to prompt personalized conversations. Now, in that last part, prompting personalized conversations, maybe they're good enough to do that if we get personalized conversations coming from the use of the tool. And I guess we would be saying that there's got to be interventions that follow the use of a tool, and that those interventions have to be evidence-based and use behavior change techniques, I guess. But would you like to comment maybe from what was said on the round table?
Yes. So I was going to say that there are tools that do exist that, that are short, quick, and easy to use. And that's also been reflected on the expert-informed review that Disha has conducted, that EVS and PAVS are, there are alternative tools that exist that perform better than GPPAQ, but also we also want to emphasize that what happens after the assessment is more important. So if the assessment is okay, then it leads to a more meaningful conversation, and what happens after that, whether it leads to more meaningful behavior change, is what we need to consider.
And unfortunately, our data from the CPRD doesn't allow us to see if what happened after the GPPAQ was administered. We can't see any detail really as to what intervention there was or whether that intervention was.
We get a little bit of coding, just like it's a broad category of nutrition intervention exercise. But yeah, we don't get any of that granular detail that presumably the GP or the nurse or whoever is speaking to the patient would be talking about. We just get a very broad coding.
And it would be tricky to then link that through to any outcome and health change from the data sets at this point. Okay, but that's, I think, a really interesting and useful conversation, and I hope that people have found the discussion today and our three excellent presentations of use in their practice and in their thinking about the assessment of physical activity. So I'd like to thank our three speakers. Thanks very much for excellent presentations today. Thank you everyone for coming and for engaging in the discussion. Don't forget the webinar is being recorded, so you can look at it again or even pass it on to colleagues who weren't able to come today. We have future webinars and those are going to be advertised on our events page. The next one is on the 17th of June at midday, so we always do them at this time of day, and it's going to be on the topic of can AI deliver for policy research, and it's evaluating accuracy, efficiency and insight of AI. So hopefully you'll come along to that in June the 17th, in your diaries now, please. Thanks everyone for coming. I'm going to cut off now so you can get some lunch, and it would be very good to keep in touch with our seminar series in the future. Bye-bye. Thank you. If the